All right, well, as I said, Dr. Waylu and Dr. Foley have set me up here and teed up what I'm going to say very nicely. And it's, as I do this work, this policy work, it is really bizarre sometimes what you see. I sometimes feel like I've fallen down a rabbit hole. So I think that what we need to do is perhaps change the title of this talk and just call it The Pain Community's Adventures in Wonderland. You've seen the numbers before. I'm not going to go over them in great detail, just to point out a couple of things. This is the number that you haven't seen before, about 39 million people who say they have chronic pain every day or almost every day. The cost of prescription drug abuse is on the order of $70 to $120 billion per year, depending on which cost you include. And Myra mentioned the risk of suicide in people who have chronic pain. And this is a conservative estimate. It's based on that risk being doubled. If you look at those numbers, then what that tells you is that out of almost 40,000 suicide deaths in 2011, about 26,000 of those were people who have chronic pain. That's not to say that the chronic pain was the only cause of their suicide, but it is part of the picture undoubtedly for a lot of them. And a lot of times we see these two problems played off against each other, but I would like to make the point that I think they're a lot more similar than they are different. Both of these are highly prevalent problems. They're both very costly in economic terms as well as in human terms. They're both highly stigmatized, and oftentimes the people who are affected by them, the patients, are blamed for having these problems themselves. There's tremendous suffering, both for the people who are involved as well as their families and other people around them. Both are very poorly understood by the medical profession. We've heard data that people in medical school get on average 8 to 9 hours of education on pain management. I'm told recently by someone who probably ought to know this, I haven't verified it, that the education on substance abuse is about 4 hours. Both are under-resourced in terms of treatment. Both are complex problems that have lots of moving parts, and both are best approached with a biopsychosocial model. So these two problems that we keep saying are different from each other and playing off against each other, I think we really have to start to think about them as being much more similar. And I think we have to check ourselves, because I think the ethical thing for us to do is to have as much compassion for the person who has a substance use disorder as the person who has chronic pain. And we have to find ways to address both of these problems without making the other one worse. But oftentimes, that's not the way it feels. It often feels like anything we do to try to rein in prescribing or prescription drug abuse must come by means of reining in prescribing, including for people who have pain. And by the same token, it often seems that anything we do to try to improve pain management means we must prescribe more, and therefore we're worsening the problem of prescription drug abuse. I think that misstates the case. And I think it's possible to address both of these problems without adversely affecting either one of these. If you think about a zero-sum game, it's sort of the case that if one thing gets better, the other must get worse, and vice versa. It's like being on a seesaw. And you've got pain on one side and you've got prescription drug abuse on the other side, and maybe the best you can hope for is some sort of equilibrium at the median. That's not a very optimistic point of view, because you can never get both of the problems up here. You can never get both of them taken care of adequately if that's your model. The model that we've used in policy, the concept of balance that was proposed 20, 30 years ago by my friend Dave Jorgensen at University of Wisconsin and his colleagues, that's this model. That's this zero-sum model. And it only works if the only treatment you have for pain is an opioid. Once you introduce other treatments besides opioids, you can begin to get away from this problem and this conundrum of how do we get past having only moderate control of both problems. H.L. Mencken said, for every complex problem, there's a solution that's neat, simple, and wrong. And I think that's part and parcel of what's going on today. John has a great word here, it's complexify, and I think part of what we have to do is complexify this situation. Policymakers like simple solutions. They like a solution that they can communicate in a 10-second soundbite. You can't communicate the solution to these two problems in a 10-second soundbite. Perhaps the solutions we need to be seeking are as complex as the problems themselves. And I don't like to cause people pain, but I do actually like to cause policymakers pain by making them think a little bit and creating headaches for them as they consider all of this stuff and how complex it really is. There's a lot of discussion about the importance of evidence-based medicine. Why don't we have more discussion about the need for evidence-based policy? Maybe it's because we don't have that much evidence that can drive our policy, and we don't feel like we've got time to develop it. Maybe that's also a misunderstanding, because we do have some very long, very large databases that could be mined to tell us a lot about what happens to people over time. If we would just look at them, we could get answers to some of these questions in a matter of months. If we have to collect prospective data on it, we're not going to have answers for decades. There's another methodology out there that might answer these questions much faster, but not having the information is when we have problems with policymakers getting into one of their favorite patterns: ready, fire, aim. I have to do something, even if it's not the right thing. And it turns out down the road that it's not the right thing. To get the right answers, we have to ask the right questions. And part of the problem is we haven't been asking the right questions. The wrong question is, should we use opioids to treat chronic pain? That's a very simple question, and it leads to a very simple black or white, yes or no answer. Unfortunately, it's not the right question. The right question is, in which patients do we use opioids? At what doses? For how long? With which adjunctive treatments? And with which precautions in place? That's a lot more complicated. It's going to take us a while to find the answers to that. Unfortunately, that's what we have to do. The war on drugs. Since the Nixon administration, for 40 years now, we've been focused on controlling the supply of drugs. It's cost us $1.5 trillion over the course of 40 years. Addiction rates have not changed a bit, and we are the country in the world that has the largest percentage of its citizens incarcerated. More than any totalitarian regime you can imagine in the world. And it's because we're doing this the wrong way. What happens is when we focus on the supplies only, we're just squeezing the balloon. In the 70s, we had a problem with heroin. We cracked down on heroin. What did we get? In the 80s, we got cocaine. We cracked down on cocaine in the 80s. In the 90s, we get methamphetamine. We cracked down on methamphetamine in the 90s. In the aughts, we get prescription drugs. And now in the teens, we're cracking down on prescription drugs, and what do we get? We get heroin again. This is silly. This is Einstein's definition of insanity, right? Continuing to do the same thing, expecting different results. We solved this problem when we let the air out of the balloon. We let the air out of the balloon by addressing the demand, by providing adequate treatment for people who have the disease of addiction, and by fixing all of the other problems that contribute to that. That's the only way this is going to succeed. We probably have to do both of these things. We have to control the supplies, obviously, but we also have to address the demand, and we haven't been. Here's another wrong question. Can we reduce the supply of prescription opioids? That's the wrong question. But that's the question that gets asked all the time, and that's how results get measured. If you look at any study that looks at things like the efficacy of prescription monitoring programs or the efficacy of pain management guidelines, what's the outcome they look at? Is there a reduction in the amount of opioid that's dispensed? Well, how much of that reduction was at the expense of people who have pain? We don't know, because nobody asks that question. If that's your goal, then just ban the opioids from the market entirely and you'll be 100% successful. But that's not realistic either. There is an appropriate place for these drugs. For certain people, there is a certain par level that is not zero. We don't know what that par level is. We don't know when we've reached it. It's a challenge. The right question is, how can we reduce the supply of excess prescription opioids? And to answer that, first we have to define what's excess. So here's an example. Florida was mentioned earlier. Florida had big problems with pill mills, these illegal operations that said they were pain clinics even though they weren't. and really just large-scale retail drug dealerships. The Attorney General, Pam Bondi, who Myra mentioned, undertook some efforts along with the legislature and along with the DEA. No more dispensing from medical practices. That's what was going on here, is physicians were dispensing these drugs from their own practices. So that's no longer allowed. They started a prescription drug monitoring program and required that it be used under some circumstances. They started registering pain clinics and subjecting them to yearly inspections by the State Department of Health to make sure they were legitimate. They set ownership criteria for pain management clinics. They said you can only own a pain clinic if you're actually a doctor. And they started cracking down on new pharmacy registration applications to ensure that the pharmacies were legitimate. And here's what happened. Some positive things. The pill mills have been virtually eliminated. There's been a big drop-off in the amount of opioids being dispensed in Florida. And registered pain clinics are being verified as legitimate. But here are some of the negative things that have happened. Now they've come along and exempted clinics that are owned by anesthesiologists, neurologists, physical medicine and rehabilitation doctors, and in some cases rheumatologists. And so now you actually have more unregistered pain clinics than you have registered pain clinics, and the unregistered pain clinics are the biggest prescribers in the state. Pharmacies are running out of opioids before the end of the month, and patients can't get their prescriptions filled. We've heard stories about price gouging at pharmacies, where a patient goes month after month after month, gets their prescription filled, has their $5 copay for their generic oxycodone, and everything's fine, and even without the copay and the insurance, it's a $35 prescription. 1 month they walk in and the pharmacist says, well, I'm sorry, we're not going to take your insurance for this anymore. We'd be happy to take cash though, and by the way, that prescription now will cost you $1,500. I've heard that story from 2 people, directly from them. People can go to dozens of pharmacies and still not get their prescriptions filled, and now even the Attorney General has says, well, maybe the pendulum has swung too far. And now she's meeting with the DEA to try to figure out how to fix the problems that they've created by trying to address this. Simple solutions to complex problems. This is what happens. The CDC, data from 2012, and as Dr. Foley showed you in 2013, these numbers went back up a little bit, 16,000 people dying of overdoses related to prescription drugs, actually related to prescription opioids, to be specific. Note that those are squishy because they rely on what's on death certificates, and the quality of information in death certificates is really scary. When the media talks about this, these are not overdoses that involve prescription opioids. These are prescription painkiller overdose deaths. Yet, there's other research from the CDC that shows that 75 to 80% of decedents used multiple drugs. 55 to 60% didn't even have a prescription for the drugs they overdosed on. And data from Florida, the State Medical Examiners Network, the first half of 2013, people who died of drug overdoses, 93.5% of them had multiple substances on board. It's not only the opioids that are killing people. How do we explain these 2 graphs? This one on the left is one of the CDC's favorite graphs. The top line is dispensing of opioids in kilograms per 10,000 population. The middle line is opioid pain reliever deaths per 100,000. So note, per 10,000, per 100,000. If you put them on the same scale, this second line is actually down here someplace. And the third line is treatment admissions per 10,000. So you see sharp increases in the amount of drugs, the amount of the number of deaths, the number of admissions to treatment. Yet at the same time, we have these data from SAMHSA looking at the number of people who said in the past year I engaged in non-medical use of my opioids. It's a flat line ever since they've started to ask about it, and in recent years has actually started to trend down. This is the number of people who say who qualify for a diagnosis of an opioid use disorder. These red lines, just for sake of reference, this line is the start of this graph, this line is the end of this graph. How do we reconcile this with this? I think there are only 2 explanations for it. One explanation is that all of these people who are dying are using their medications exactly the way they're prescribed. I don't think that's very likely. The second explanation is that these people who are dying are still these same people who are misusing, but they're misusing in a different and much more dangerous way. And that needs to be clarified. What is that way? Because getting from a prescription to dying of that prescription, there are hundreds of routes by which you can do that. You can go home and take your medication exactly as it's prescribed and die of an overdose. You can go home and take your medication from Dr. A, your opioid from Dr. A, and your benzodiazepine from Dr. B and die of an overdose. You can go home with your medication, you can crush it and snort it up your nose, and you can die. You can go home and take your bottle of oxycodone and wash it down with a bottle of Jack Daniels, and you can die. We have no idea how many people follow which path. And if you knew that, then you could target specific interventions that would have the greatest impact. But when all you have is this graph, the only solution to bring this middle line down is to bring the top line down, to reduce the amount of opioid that's out there. It's an oversimplistic view of the problem. Once again, it points to a simple solution to a complex problem. So here's another thing that's really nice, and this is my last point. CDC's proposed lots of responses to this, most recent of which was in January of this year. They put out an RFP. They intend to develop opioid prescribing guidelines. And this RFP is to provide research support for the development of opioid prescribing guidelines, including conducting literature reviews, synthesizing research, assembling evidence tables, and providing editorial support for draft clinical recommendations. Well, that's nice. But in September of last year, the NIH sponsored a workshop called Pathways to Prevention. Myra was one of the speakers at that. There was an extensive evidence review that was carried out in advance. And after the meeting, there was an unbiased panel that developed a report based on what they heard over the course of these 2 days and all the evidence that was collected. And what they said is, there is insufficient evidence for every clinical decision that a provider needs to make regarding the use of opioids for chronic pain. So if that's the case, where in the world is the CDC going to get their evidence for their evidence-based guideline? And why is it the CDC and NIH are not talking to each other about this? So with that, talking about the need for us to have more evidence and to rely on it, I'm going to let Katie give you some actual evidence.
Thank you. And thank you, John and Myron, the center, for having me. It's really terrific to be out of Washington, D.C. I told a couple of folks last night, I'm embarrassed to say this is my first time in this beautiful state. And that's particularly tragic because my father grew up here, a little town called Purdy, Missouri. Has anyone ever heard of Purdy? Okay, Wikipedia last night told me less than 1,000 people. Famous for its Supreme Court case to ban dancing in that town, apparently. So now we've all been educated about Purdy. You know, when Myra called me and asked if I would come today, I was a little bit hesitant, truthfully, because I'm not a pain expert. I have done some research, thanks to the Open Society Foundations, looking at really the evidence base of some prescription control programs, and we shared that with them. But really, I think as I talked with Myra more, what I can bring to the table here is a little bit of perspective about the policymaking process. Capitol Hill. I worked there for over a decade for the Senate Finance Committee and the Ways and Means Committee, two big committees responsible for the health legislation. And it's not a pretty picture, and I appreciated very much your points about both in terms of this shouldn't be a debate just about prescription drugs and pain. I also appreciated your point about money and policy. And it is true. I worked for Senator Moynihan, and he loved his academic medical centers, loved them as if they were family members, loved them. And he viewed his role as to protect them. And it's part of our system. It just is. And so as much as I'd love to talk with you about broader reforms, I'm with you on all of them. I've been asked today to sort of talk about the current state of policy, What are the politics? How can you all, in a pain context, get out there and talk about your message and make a difference? So, let's see here. Uh-oh, that's not a good sign. Oh, gotcha, okay. So I should say also that at GW, we teach all of our master's students how to advocate. We think it's critical. It's a core course, they all have to take it, and now we're talking about changing the curriculum for the medical school so that all medical students also have to know how to be effective advocates. It's really an important part of caring for your patient. So let's talk about quickly the work that we did. We were asked to look at the literature and begin to grade the literature and evidence around access to pain treatment, racial disparities in pain treatment, substance use in patients with pain, diversion to street drugs, and access to substance use treatment. We focused our research in large part on prescription drug monitoring programs. I know most of you probably know what these are, but these are statewide electronic databases. At the point of dispensing at the pharmacy level, they enter in data, and it's a way, supposedly, for physicians and others to track who's getting prescription drugs, how often, where. We also looked at Medicaid lock-in programs. Less known, these programs are really becoming quite common in the states. And in these programs, Medicaid beneficiaries are required to obtain services from only certain designated providers if they're found to have used drugs frequently or in a way that's not medically necessary. And I think for us, it raised real questions of equity, fairness, and really a lack of oversight in both of these two areas. We talked with a number of experts, many of them in the room here today, about their perspectives on these programs and wanting to better understand the data and access issues associated with some of these prescription drug programs. Many of the themes we found we've talked about in this meeting: multiple reports of racial disparities in access to pain, racial disparities in some physician prescribing practices, limited information on how to effectively manage care for patients with both substance use disorder and pain, and really a significant limited amount of information and data on effectiveness of prescription drug control programs. What's interesting now, and we're going to talk about this a little bit, Congress is, I'll use the word someone used earlier, a tidal wave of legislation and hearings and oversight around trying to get their arms around this problem. And it is, it's really very, very significant. And we don't have the evidence. They're replicating these programs in legislation, giving millions of dollars to these programs that may or may not be making a difference, to spread them, to expand them, and it's an issue. And again, the concern we've all talked about today is that aggressive prescription drug control policies could further diminish access to treatment for pain patients or certain subsets of pain patients. So there's this tension. And I think the question for me is it an opportunity or a difficult challenge? You've got the federal government moving very aggressively to regulate in this area and to legislate in this area. On the other hand, you have the IOM, the National Pain Strategy, and the Interagency Pain Research Coordinating Committee and others moving forward with good calls to action around improving research, management, and treatment of pain. For the pain community, is it an opportunity or a really difficult challenge? I've looked at the legislation, I read it last night. I think there are opportunities here, but on whole, I think there are more risks than opportunities. And to your point earlier about tidal wave, I think it's really important to deal with the current political environment, to know how to advocate in it, and to take action. Let's see. So we're seeing in some of these bills really a blunt knife, replicating some of these programs that don't have a lot of evidence behind it. Just a little touch of just the hearings in the last few months. What's the federal government doing to combat opioid abuse epidemic? VA opioid prescription policy practices and procedures, combating the opioid abuse epidemic, professional and academic perspectives, on, weekly hearings on this topic. It is a drumbeat. One thing that hasn't been talked about why, I personally believe a lot of it does have to do with our political system. A 2-year election cycle in the House moves members of Congress to try to do something quickly, regardless of the level of evidence. They have to produce, they have to show that they're reacting and responding to what they're calling a national epidemic. Again, just a small sample of the number of bills that have been introduced, replicating many programs and policies that don't have the evidence behind them. Importantly, what I think is lacking from many of these bills is what I would call sort of a stopgap, a provision that would say we can test it, we can try it, but we're going to look back and evaluate it. If it's not working, we're going to abandon it. And a lot of these bills are lacking that kind of provision. Also on the administration side, we have a new Secretary of HHS, Secretary Burwell from West Virginia, where there is a very large prescription drug problem. And she has come out with, from the administrative side, an initiative to combat that. Again, another drumbeat. More, we must do more quickly. And some of this is good. CDC, you see, putting in millions of dollars more for their work to expand PDMPs and to do more aggressive work at the state. This was in their budget. The president's budget, again, $100 million. More drumbeats, more, faster, quicker. We've got to respond. So how do you find the balance between treating addiction and treating chronic pain? I think it's a real challenge. To me, I think we have to build the evidence base, right? We're seeing a real lack of evidence base. And so that's an important thing to do, to partner with PDMPs, to partner with Medicaid lock-in programs to see if they'll give us access to data to begin to really look at what's happening. But also to respond within the current political environment, you have to create this coordinated advocacy campaign. You may not love the current system. I don't love it, but it is what it is. And the worst thing to do is to have Congress do something to you, I think, without having been involved. So I should say that when I left the Hill, I became interested. I was really privileged to have 20-some meetings a day with lobbyists, all advocating passionately for something they needed urgently, whether it was more funding or more access to care. And so you begin to learn what works well, what persuades policymakers. And I took that when I left the Hill and did a lot of research, asking committee staff, policymakers, doing surveys, what pushed policy, what made the difference to you? And what we heard really was a lot about an advocacy campaign, a multi-pronged campaign that I'll talk about in just a minute. Again, I think this need, absence evidence doesn't eliminate the need for advocacy. You've got to move forward with some kind of campaign now. This is the campaign idea that we've developed and we teach at GW. It starts with research and policy studies. These are not, great studies. They are studies that respond and react to policymakers, that talk about return on investment, that talk about impact to Medicare and Medicaid, that resonate with policymakers. They're not randomized controlled trials, but this is what people use on the Hill. You take these policy studies and surveys, and then you build a lobbying and coalition effort. And I know that the Academy, and while I know, Myra, that you all don't advocate directly, you do great education up on the Hill. And there are a number of folks doing great work in this area. But creating this coalition building, this sophisticated lobbying effort, really critical to the success. You build your grassroots and your grass tops. These are folks that can pick up the phone and talk to the member of Congress. And the media and public affairs piece, really critical. We saw some great clips last night that I hope you all will use on the Hill later. And it's this coordinated campaign that policymakers told us makes a difference to them. It's the drum beats, the constant messaging. And so as much as I would love, simple solutions not to be the case on the Hill, it is who you're talking to. You're talking to 23-year-old staff people without significant backgrounds that respond to emotion, putting a face on the issue is super important. And so I love this quote from Ben Franklin. If you would persuade, you must appeal to interest rather than intellect. And as sad as it is, I hate to say it, this is my experience on the Hill. So with that, I will turn it over.
So it looks like we have a little while for questions and discussion. So anybody want to say anything?
Yeah, could you, in that slide where you show the increased number of deaths versus the number, so why haven't you made another slide?
Which is?
With the slide you're talking about, if we did it on the percentage of 10,000, then it would
Oh,
look down here.
yeah.
So, you know what I'm saying? I mean, I think we need to call the CDC, we have to put the fact, that's the myth and this is the reality
Right.
kind of aspect.
Right.
So I'd love a visual like that.
You know what's striking about that graph is that comes from an MMWR report
I
that
know,
comes
yeah.
out of CDC. And if you read that report,
Right.
there is not a single correlation statistic in that entire report that correlates those lines.
I see, okay.
It's an eyeball test of significance is what
Sure,
it is.
yeah.
However, if you sort of take that graph and impute the numbers and run the correlation coefficient, it's like 0.9. So I mean, clearly they're highly correlated. But yes, why present it in those terms instead of in the in the real terms? Because it doesn't have the same visual impact. And this kind of gets to part of what's going on at CDC is that there's a lot of public relations around this. They call the problems that we have with opioid abuse an epidemic. What they
Right.
say about chronic pain sounds a lot like crickets chirping to me.
Mm-hmm.
And I think what they ought to be calling it is a pandemic. If prescription drug abuse is an epidemic, then we got a pandemic of chronic pain.
But coming back to that particular one, in the rise of overdose deaths, the point is we don't know that those individuals had prescriptions.
That's
We
exactly
know they
right.
used prescription, but we don't know that they. But the point I'm making is it's
Yeah.
not related to the other because we don't know they. So,
Right.
So we have to take them out on that.
Well,
don't
so
you think?
that's the second problem here is that first of all, they don't prove there's a correlation.
Right.
But then if you read the text, they come about this far from saying there's a causal relationship there, which is what we teach people in the first week of statistics class not to do.
Yeah.
And the CDC is doing it.
Yeah, but I do think that they are sensitive to critiques. So it does seem to me that that would be a great maybe graph to take out.
Yeah, great.
Yes, sir.
Yeah, I'm Jan Russo is my name. I'm a clinical psychologist. I'm very concerned about the neglect of what we call psychological issues
Yeah.
involved in pain. And I think that one of the reasons that there's so much emphasis politically on things like opioids is because the pain people are not paying attention to other issues or not saying they're there. For example, I know through training of helping people increase their attention and concentration skills that their pain is reduced. Now it makes sense in terms of blood flow studies, in terms of pain receptors versus executive functions areas, that would be an issue. Now that would have to do with everything from employment to education to financial positions that they're in. And we need to be looking at the total picture when we're talking about pain.
Yeah.
The total picture. Now, we're not looking at it. We get simplistic, not just simple.
Yeah,
The whole damn thing. And I think, for example, Dr. Beck here talking about emphasis upon other aspects of the body functioning is another part of it.
Right.
So
Yeah, a great point. You want
well,
to
and
respond?
as a psychologist, I have
It goes
to.
back to when you're talking about factual base.
Yeah.
It's
Right.
got to be more inclusive.
Right, exactly. Well, and as a psychologist, obviously, I'm sympathetic to, to the concerns of addressing the psychological aspects of pain. We also have to address, the cultural aspects of pain, the pervasive cultural attitude that there's one pill that's going to solve all my problems. I think that's got to be addressed. The notion that people have to be part of their own care and have to take an active role in helping to manage that is something we have to address. We have to address reimbursement so that all of these things can be paid for. We have to address the workforce that provides the psychological services and the PT and the acupuncture and all those other things. We have to address the education of the medical workforce so that they understand when and how to use those people. Again, it's not a simple problem. It's complex and lots of pieces that we have to address to fix it, but if we don't start addressing those pieces, we're never going to get anywhere.
Can I just build on that, and also to respond to the earlier question about reimbursement systems? You know, I think with the Affordable Care Act, you either love it or you hate it, but embedded within that law, there are a number of what we call delivery system reforms that hold great promise, I think. Accountable care organizations came up earlier. Medicaid health homes that would pay a single fee to basically a group to allocate dollars to providers for services they believe most important. Maybe that picks up on some of the issues you raised. So it doesn't have to be in the traditional medical model. They're creating new delivery system reforms now to try to respond to exactly what you were raising. There's an innovation center at CMS now, testing all kinds of new delivery system reforms. And so I think I'm excited about that prospect. I think they hold great promise.
Yeah, and one other aspect of the Affordable Care Act that doesn't get talked about much is Section 2706, which is a non-discrimination provision that says that any licensed healthcare provider who's acting within his or her scope of practice must be reimbursed for the services that they provide. They don't have to be reimbursed at the same level, but if you're a licensed healthcare provider and you're acting in the scope of your practice, then the law says you have to be reimbursed. HHS has not been helpful in the way they've interpreted that, actually.
Yes, we have.
Hi, I'm Joy Whitert. I'm Associate Professor in Pediatrics and Integrative Medicine at the University of Kansas, so just across the state line here. And for the last 12, 13 years, most of my practice has been working with children with chronic pain. And in the model that we have, a lot of kids came to me because of being on chronic opioids. And through our model with a clinical psychologist, a massage therapist, working on nutrition, working on lifestyle habits, working with stress levels, all that kind of stuff, I think we've been very successful in getting these kids off their opioids, back into schools, back into their lives, and doing things. So when you talked about the need for evidence-based medicine to support this, there's a lot out there, but we are, as a medical group, we are choosing not to look at the evidence. And it's unfortunate because if we keep doing the same old thing, like Bob said earlier, we're just going to get the same old results. And when we look at some of these models, these system models, multidisciplinary models, in the work that they've done in children, they've had success, but when you look at it long term, it's really only 50-50. So we're not getting long-term success because we're not really dealing with the underlying problems. And if we don't start treating the underlying problems, a lot of it's nutritional, a lot of it is our diet, our lifestyle. If we don't start treating the mechanical underlying problems, if we don't look at what the underlying problems are, we're going to keep doing the same things over and over again. So
perhaps in a way, we're, even with those multidisciplinary models, we're treating a chronic problem with an acute model.
Exactly.
The article that you wrote with Rebecca Kirch, if you haven't read that, I would really highlight that to each of you. It's fantastic, and I think the supply-side dynamic that you talk about, the policy response all being toward the supply side, is a very potentially dangerous thing, getting to the prevention piece of it. The prevention piece is so important. Things are moving really quickly with implementation of the Affordable Care Act. So you're finding these little tidbits of gold that come out. For example, in the final 3,000-page regulation on the essential benefits and exchanges, there was a small provision that said, my goodness, now Medicaid can reimburse community health workers, non-licensed professionals. I mean, to go to your point about, really trying to look more comprehensively on the prevention side. So there, I'm seeing great nuggets and great movement, uncovering them and making sure folks know about them. Another thing.
Hello, my name is Morjana. I'm an associate professor of strategic communication with the University of Kansas, and I'm also the director for the Center for Excellence in Health Communication to Underserved Populations. I want to start by congratulating all our speakers for a very comprehensive and also very focused view on different aspects of chronic pain, opioid addiction, political issues. But as I was listening to you, I was just thinking that something was missing. And I really want to say that looking at the proposed advocacy campaign, it was great to see it in there, and that was media. How do you outreach to the general public? Because last year I've done a very short research on the way media talks about chronic pain. And every time there's a discussion about chronic pain, there's also a discussion about opioid addiction. But there's a lot of discussion about opioid addiction out there, and nobody talks about chronic pain. So what are you doing in order to outreach to the public sphere? And what do you do in order to try to change the media agenda from one that's focused on addiction to one that's really focused on the real problems associated with chronic pain? Thank you.
Well, that's a tough problem because, as you know, trying to get the ear of the media and put out a message as opposed to respond to things is a real challenge without having a high-powered public affairs or public relations campaign that does that. I will tell you that the number of calls that I get from media has jumped dramatically over the past few months. I'm sure it's probably true with Lynn and others in the room too. And I know Dr. Webster's been writing a lot of op-eds and so forth that have been published. So I think you're absolutely right. We have to start doing a better job of trying to get that message out there other than in response to other stories that come up.
I think that also goes, that little diagram that I showed at the end, that's your campaign structure right there, and media, public affairs, a primary component. It speaks to your coalition members. No organization can do it alone, but you want to bring together a number of organizations that have a variety of resources, a variety of mechanisms to reach different policymakers and different audiences. So there's the way we design sort of the media piece of most campaigns for Washington. There's an inside the Beltway piece and an outside the Beltway piece. Two very different tactics and strategies used for both.
Yeah, and what you say about coalitions is really important. I mean, that's the whole notion behind our SPAN coalition, as well as one of the projects we undertook with that is something that's right now called the Consumer Pain Advocacy Task Force, where we convened 17 different consumer advocacy groups related to pain and got them all to sit around the table and talk to each other and work with each other. And right now they're in the process of making a coordinated response to the National Pain Strategy. It's the first time this has ever happened. So to finally get everyone organized and on the same page and putting out the same messages is a key, and it's beginning to take off and gain some traction.
I guess I'm next. Celeste Cooper here. I'm a registered nurse, and my clinical background is in hospital education and training and in the emergency department. And I am now a chronic pain patient and part of the Relieving Pain in Kansas City initiative. One of the things that we're going to be trying to look at through that initiative is ways that we can improve the way pain is perceived, judged, and treated through collecting data and finding ways of doing that. One of the things that I particularly am interested in, Bob, is one of the slides where you showed the overdose related to opioid deaths. One of the things that I saw as a emergency nurse is what happens when somebody comes in with an apparent drug overdose. Of course, we draw toxicology. It goes in the medical record from the emergency department. Then it goes to the medical examiner. The medical examiner then weighs in on that. How many times are we also collecting data on drug interactions? A lot of times the patient that's on opioids does have a psychological effect. They may be on an antidepressant that potentiated the effect of the opioid. Is that ever mentioned on the death certificate? Do we get that data from the death certificate? Is there something that we can do to improve that?
Well, that's a huge mess. Frankly, the dependent variable here, the number of overdose deaths, is a real problem because, first of all, the people who sign death certificates vary widely. I mean, you may have the best forensic pathologist in the country signing a death certificate, and you may have a county coroner who's the guy who owns the funeral home signing the death certificate, or the gas station for that matter. So there's a real quality problem in terms of who fills that out. The amount of data that they have when they fill it out is really questionable. The format of the death certificate itself is a problem because it doesn't allow you to adequately describe what's going on. And I know I've seen Dr. Webster do a talk about a proposed revision to the form that would help us a lot. So, they put these numbers out there as if they're the gospel truth, but if you really start looking at the quality of those numbers, it's a mess. And I actually ran across a report in the media this week where in Texas, they've gone into county medical examiner offices and started looking, and they find that there are a whole lot more people dying of overdoses with opioids on board than is even being reported by the CDC. So it's a mess, but we're making policy decisions for the entire country on the basis of this mess.
Which brings me to another question. The family sometimes has a lot of input. And I think in some situations, they may not be ready to accept at the time that data is collected that possibly the overdose was intentional.
That's right.
And
not only that, they don't want it to be recorded on the death certificate as an overdose death, whether it's suicide or whether it's accidental, because, does that imply that somebody's got a substance abuse problem? And I think particularly in small communities, that gets played out quite a lot. Yeah.
We have some back of the, yes, go ahead.
I'm Don Giffen, the same person who spoke to you a while ago. I have a couple of comments. One is that it seems to me that the medical community has fractionalized itself to the point where it has biological, psychological, sociological disciplines. And from my experience with these disciplines, about the only thing they can agree on is they want to blame the political. And they're very, very competitive. And it seems to me that this is one of the reasons that we're having such a difficult time with this problem. The second one is what I consider the almost obsessive concern that the medical community has with statistical evidence, to the point that they almost totally disregard anecdotal evidence. It's just not evidence at all to them. And it seems to me that we've gotten the cart before the horse. We're trying to get to the statistical evidence without ever having looked at the anecdotal evidence. And where will the anecdotal evidence come from? Well, from my experience, the best anecdotal evidence comes from investigative reporting. And if we could find a reporter who would spend 3 or 5 years working on this story, developing the anecdotal evidence, we would be able to convince the public, I think, that the problem is more complicated than a simple soundbite. And that would be my comment and why I think we're struggling with this problem, which probably has a solution, but it's maybe 10 or 20 years down the line.
Right. Well, and of course, part of the challenge is the anecdotes cut both ways. But,
Sure.
And the other, another thing that's really important, I think, to say here is that we're looking at this from the 30,000-foot level. If you get down on the ground and you look at a situation when you're somebody who's a healthcare provider and you're in a room with somebody who's a person with chronic pain, the truth of the matter is that every case that you take is an N of 1 experiment. You use all the evidence you've got, but all that does is really give you a starting point and some ideas about where to move next. But it's all about the relationship between the provider and the patient and how you are able to start something, see what happens, and make adjustments until you get it right. So evidence is valuable, it's helpful, it may help guide policy, but in the end, the kind of policy we need is policy that's permissive, not prescriptive, that just allows us to be able to do that with someone, to have the time to sit and hear the whole story and understand everything that's going on and pull everybody in. It needs to be part of fixing it. So it's, evidence is nice, but it's not the be-all and end-all.
The number one thing that makes a difference to a policymaker truly is a constituent with the problem. So you'll see different medical associations bring a patient with them when they advocate. So maybe it's a physician and a patient The patient is what makes the difference, honestly. It's the story, it's putting the face on the issue, it's a voting constituent. That's what members respond to. So I think you're right on the anecdotal piece.
So I'm back here, and I wanted to build on that and make a different kind of political opportunity point, which has less to do with Congress and more to do with the presidential campaigns. You know, the reason why we have a prescription drug benefit in Medicare has a lot to do with the 2000 presidential campaign and the swing state of Florida and promises that were made in Florida at a very crucial moment during an election that put that on the priority of a president to deliver. You can debate about the pros and cons of that as a process, but that was really key. So I wondered if there's an opportunity that's created by the coming political campaigns. And I'll sketch it out this way. That, you know, for good or for ill, we have a campaign season that starts around now that culminates in 2016 in November. And we have a kind of, you know, an electoral college that focuses on swing states as the crucial place where these issues are played out. And at the same time, as you just mentioned, we have an addiction, tendency to sort of think about the addiction politics as driving it. So you go to Kentucky, where Rand Paul is from, and that's what they're grappling with. But they're actually beginning to explore what you might call liberal approaches, as they are in Indiana, for how you deal with addiction, how you deal with problems relating to drugs. And then you have these sort of libertarian tendencies that are part of the Republican Party. They're there from Texas to Kentucky. And the question is, are people on the left and the right open to thinking about not addiction, but using whether you can use the addiction concern to say, yeah, we should deal with, you know, problems of overuse, but let's not also lose sight of something really crucial, which is, you know, not hindering compassionate care. Mm-hmm. I think that there are candidates out there that are interested in this. So one of the questions would be, one, which states are really crucial in helping that? I mean, because the candidate is going to be taking that message to a state that they want to win. On the other side of the ledger, you have, I don't know whether you saw the New York Times this morning, but it was a story about how Hillary Clinton has to account for the fact that her husband really continued the war on drugs, but we're in a different political environment in the Democratic Party, where Democrats are now grappling with the excesses of the war on drugs. So it strikes me that from the left and from the right, you have the opportunity for one candidate or the other. And, you know, people like Rand Paul have been trying to kind of do liberal politics in this space because a Republican is going to have to win some of these swing states. So I guess, you know, this is a long way of saying and the way these arguments get planted in campaigns have to do with key advisors who are susceptible to some of these messages, who see the political advantage, right? I mean, George Bush Jr. didn't come up with the idea of a prescription drug benefit. Al Gore's advisors came up with that, and then the Bush campaign said, we have to go there too. He went there reluctantly, but lo and behold, we ended up with that legislation. So I guess what I'd be interested in is thinking about what are the political opportunities that are created as a lead up to a presidential campaign where you have, to be honest, people who are willing to say anything to get elected and are willing to use any potential advantage, anything that could have resonance. And they're particularly attuned to specific states where these arguments have resonance. So this is not the reaching the public, because this approach says it's actually not the general public that matters. Right. It's a particular state, maybe 3 or 4, where you can kind of generate a conversation that drives a political discussion. So it's an open I wouldn't say this at HHS, which but this might be a good strategy for an organization like this, or for those who really are seeking reform.
Well, I can tell you off the top of my head that two of the biggest swing states are also two of the states where there's been the biggest issues around this, and that's Florida and Ohio. And Ohio is the biggest swing state of them all, of course. And those are both states that have taken lots of actions to try to control prescription opioid abuse and created problems in terms of access to pain care.
So how do you highlight that,
right,
and make that an issue both in the states but also on the campaign, on the agenda of some of these individuals?
Right, and in Florida, it now is rising to at least the level where United States senators and attorneys general are aware of the issue. The question is, how do we get it to the next level and get it to the presidential candidates and make it become an issue for them too?
I think it's too early to tell which advisors. I mean, you know on the Democratic side, for example, Jean Lambrew, Chris Jennings, Yvette Fontenot, the usual cast of characters will line up when it's time. I think it's too early yet. I thought we were starting to get into a conversation earlier about how interesting it is. You've got marijuana laws happening. The one thing look at Baltimore, I mean, Ferguson. My personal hope is that some of this begins to really look at a harm reduction, criminal justice reform message. I mean, folks that are thrown in jail for small drug possession. I mean, isn't there a way to connect these folks to better healthcare services? I mean, that's one message I hope I hear coming out of some of these reforms. One more question.
Great, thanks. Well, I want to thank all the speakers. It's been just a terrific day, and thank you, Dr. Walu. I bought your book, and I'm excited to read it. But I just wanted to make a quick kind of comment and maybe challenge for us here. My name's Amy Goldstein. I am with the American Academy of Pain Management, so I get the pleasure of working for and with Bob every day. And in my role, I'm director of the State Pain Policy Advocacy Network, which we've talked about, where we track all the policies. And I've been learning lots. And I'm connecting, my role with SPAN is sort of connecting the dots across the country and trying to move collectively as best as possible to advance person-centered policies for pain. And as I'm kind of connecting a lot of different things that have been said, I think there's a real opportunity here in our city to think about, I work with Cindy and Myra and Ann and folks with pains and lots of other folks. And with the American Academy of Pain Management, one of our very top policy priorities is access to integrative pain care. And that was because our stakeholders absolutely see that as a number one need. And I think for some of us, it feels disappointing that the conversation is often around drugs and prescription drug abuse when it's not really what we want to be talking about. It's what we feel like maybe we have to be talking about. So Bob mentioned Section 2706, and I just want a quick second to mention that. So we are working with another organization called the Integrative Healthcare Policy Consortium, SPAN, and this IHPC to actualize and operationalize some structure to address Section 2706 and make a difference and start to talk more collectively to state insurance commissioners and so on to make some changes. That's just one example of a tangible way to improve access to integrative pain care to all the disciplines. And I just wonder if, connected to gentlemen over here saying let's do more kind of social media public awareness to highlight this side of the problem, and perhaps in Kansas City we could bring a few people together, and instead of stressing out about doing it nationally and making everyone do it, but just have us all see if we can work together to push out the same messages. We at SPAN and the Academy are committed to some social media strategies, and we're starting to do that differently and just invite the input and the ability for us to be collective here among a lot of different groups. I'm looking at both of you and thinking, you know, it would be great to have you both involved and anyone else. And unfortunately, I have to leave in a few minutes, but I'm going to leave some cards and give them to Bob or Cindy or someone. If any of you are interested, I'm very happy to have you email me, and can do the kind of back end working with all of us together. But just wanted to mention that. Thanks.